All right, for those of you that are on the meeting, thank you for joining us for the presentation this morning on substance use disorder treatment and recovery. We're fortunate enough to have two experts in this field, each bringing their own perspective and experience to this issue. We have Dr. John Asriel. He'll be presenting on medication-assisted treatment for opioid use disorder, why it is underused because of stigma, and the biologic nature of addiction. Dr. David Douglas will be piggybacking on his last presentation on the history of the drug war and expanding on how the war on drugs caused the stigmatization of this health issue and provide us with information on the use of person-centered language to reduce stigma. So just a little background on our presenters. Dr. Asriel is a native of Kentucky, where he spent 25 years in rural family medicine practice. His interest in rural medicine and rural medicine education brought him to Ellensburg, where he's resided for the past 11 years. Recognizing the underuse of buprenorphine, despite its effectiveness, along with recognition of the misplaced stigma of addiction, led Dr. Asriel to advocate for medical treatment of opioid use disorder. The poor level of understanding of addiction in our society and recognition of the value of medical treatment for other addictions led him to make addiction medicine a significant part of his practice. In 2020, he established an addiction medicine program at KVH, which despite COVID is working to provide access to medical care for patients with opioid and other addictions, and hopefully will help our communities to better address addiction in our county. And Dr. David Douglas has been a member of the Kittitas Valley community for almost 20 years. He teaches at Central Washington University and has worked with the campus to create a recovery community framework. David is on the Kittitas County Mental Health and Recovery Board, giving guidance to entities in the community, seeking to improve access to recovery supports in this field. David recently completed his doctoral degree where he has done research and work creating trainees to teach about this substance use disorders. David is a person in long-term recovery from a substance use disorder and brings a perspective to the trainings where he provides the lived experience in accessing multiple systems along the way to recovery. He's created evidence-based trainings to support helping people learn how to effectively help people find a path to recovery from substance use disorder.
Hey, all right, everybody. I'm glad to have you all here to talk with you. Appreciate your special position and the contact you all will have with people that have addiction problems. So glad to get the chance to work with you. Let me start by saying that when a person with opioid use disorder enters a program that uses either buprenorphine or methadone for treatment, that person's risk of death drops to less than half. Despite such effective treatment, most people, more than half of people with opioid use disorder, do not get treatment. And of the ones that get treatment, most do not get treatment with these effective medications. So you look at why would that be? And think about, is there any other condition that has a high mortality rate and has effective treatment, and most people with that condition don't get treatment? It's hard to come up with anything else. And the reason why is the idea that we as a society generally have about the nature of addiction and about the role of medication for treatment. You ask most people about medications for treatment of opioid addiction, they will say something on the line, well, medication's a crutch. What the person really should do is develop the strength of will not to use drugs. For those who can't or won't do that, maybe it's okay to take another drug for just to treat it for a while, but only for a little while, because after all they're really doing is substituting one addiction for another. And let me say, that's not what treatment for addiction is about. It's very different than. Matter of fact, that's not the correct understanding of what addiction is. So because you all are in a situation where you're going to have a real chance to talk with people or know people that have substance use disorders, I want to try to take this chance to let you understand the role of medication better, hoping that as people in society understand it better, we'll have better success at getting people into treatment. So before we start, one word, I'll be talking about buprenorphine, trade name Suboxone, mostly because that's what's available in offices and is the best treatment for the large majority of people with opioid addiction. I don't want to neglect, however, another life-saving intervention, which is naloxone or Narcan distribution. That has the ability to reverse overdoses, and getting Narcan available to families and friends and people with addictions is a big step towards reducing death from overdose. Now, that's what we call a harm reduction technique, where it doesn't really treat the addiction, but you kind of live to fight another day. It can cut down the complications of addiction to allow a patient to, well, live and then hopefully address the addiction later. Do need to understand that when we talk about treatment with these medication addiction, however, this is very different. We're not talking about harm reduction. We're talking about a treatment that gets to the core of the brain disease of addiction and actually does treat the addiction. And I think that misunderstanding, where we're not just doing a safer way of providing a drug to a patient, the misunderstanding is a lot of the stigma of treatment for addiction and, again, of addiction itself. So let's get started with our journey here. And we're going to start with this obviously intelligent, charming doctor here, and his first exposure to a drug and continued use of that drug. And here is where that started. And this is the mountains of Guatemala, where medical team would be up early in the morning, cold mornings, wrapped in blankets outside of a hospital. And these people would be around to help make it easy to use a drug. And here's the drug, which I also have right this very moment, which, as you can see, is a very appealing delivery system. It's in a hot and tasty liquid with an enticing aroma. And even though I had gone through many, many years adult life without using this drug, in this situation, it was just very tempting, and I started using the drug. At that point, I returned after that to my practice in Kentucky. And at that point in my life, and I do have to admit, this is me I'm talking about. At that point in my life, I was rather chronically sleep deprived because of a heavy obstetrical practice and working in the hospital with medical residents and such, and found when I used this drug each morning, I was a little easier to get along with, honestly. I was more pleasant, a little more talkative, less surly, and the result of that, since it started with rounds in the hospital for the residents, was happy residents. But I realized after a while that there were some days that I wasn't so pleasant. It took me a little while to put together that was days I just didn't get around to getting the drug in the morning, because I liked it, but it wasn't anything all that special. And so when I found that was without it, things were not so good, really. But then realized, well, I have to then just make sure I always have it. And so with it, we go soon with you, then find that everything's great again. So the question for you, as we look at me in that, is, am I describing addiction? And if you all anyone wants to type answers in the chat box, we will look at them, of course. And I guess in our Zoom setting, I have to ask you just to answer that question for yourself. Is this addiction? And to answer that well, though, you need to really say, what is addiction? So what I'm really asking for to start with is a definition of addiction. And if you were here, I would maybe embarrass somebody by calling on you and ask you to answer the question. But let's talk about what that might be and such. So is it just using a drug? Is using a drug, even using a drug regularly, like I was describing myself doing with caffeine, is that addiction? Is withdrawal when you don't have an addiction? And I will tell you, this is, I think, a good definition of addiction. This is an old definition of the American Society of Addiction Medicine. And much of what we'll do in this talk is really break down the components of this definition so we understand it well. So we would say addiction is a chronic relapsing brain disease, that's the location, but it's characterized by compulsive drug seeking despite harmful consequences. So that's what really, it's a behavior rather than the use of a drug. And you look at my behavior, was I showing compulsive drug seeking for that? Let's say no. I was not finding my use increasing. I wasn't having to plan my day around using. I wasn't neglecting any responsibilities to use. As a matter of fact, I just didn't always even get around to it. And so I'd say I suffered no harmful consequences. I was not showing tolerance. So what I was showing really was not addiction. It wasn't the behavior of addiction. So what was it I was showing? Well, what I was showing was withdrawal when I don't use it, physical dependence. However, there are several medicines that cause physical dependence, some blood pressure medicines, antidepressants, and of course, opioids. But having symptoms when you stop using it suddenly is not the same as addiction. I think that's first thing to understand, because many people think they're the same thing. So, okay, back to our definition. I have to say that when I was at a meeting once with some of our excellent behavioral health people, and one of them, when we're sitting at a table talking, was saying, I recognize the value of the medications for treating addiction, but I can't buy that it's a disease. It's not a disease. It's a maladaptation to childhood trauma. So that's our next question. Is there really a biologic nature for addiction? And the question I would ask you, or here, it had to do with the drive, the creation of that drive, that compulsive drive to use. If you take a newborn baby and that baby is put in foster care or adopted, as that child grows up, what do you think is the single biggest predictor of that person developing a substance use disorder? So you think about that for just a second. You might think about the answer. Say, even though things in the environment are very important, what they're exposed to as they grow up, how successful they are in school, and so forth. The single biggest factor is the presence of a substance use disorder in their biologic parent, even if they've never met. So that shows it's clearly got a biologic nature to it. And the source of that is in the brain. And so I think our next step is to look at what is addiction from a brain level. And we're going to talk about the neuroanatomy and neurophysiology of addiction. And please don't glass your eyes over or get up, leave at this point. For any of you all that have healthcare training, this is a spot where most doctors start groaning with bad memories about having to learn about these things in medical school. I promise you, this will not be painful. Matter of fact, you might even find it interesting. So keep paying attention and don't zone out at this point. But we're going to talk about the brain aspect of addiction. And the first thing is, what neurotransmitter, what chemical is the neurotransmitter of addiction? All this has to do with what substance. And many of you have probably through school and such heard the answer to that and know what we're talking about. It is dopamine. So what we'll be talking about is the effect of dopamine on different areas of the brain. And the areas of the brain that are most concerned to us here form what's called the reward pathway. So this is the area that reinforces learning and helps us learn what is good and what is bad, and therefore good for survival. And if you look at this, you'll see that there's three areas particular that we'll be looking at, and two of them, the nucleus accumbens and the ventral tegmental area, are deep in the white matter of the brain, the very primitive area of the brain, the area of the brain has to do with functions such as breathing, temperature control, but does not have to do with conscious thought. Emotions are here, fear, fight or flight, those things are centered in these areas of the brain. This is the area of the brain that has you do things without conscious thought, such as if one of you all were to walk by me with a plate full of food, my eyes would turn to look at the food with no conscious thought of mine. If one of you ladies, after a talk like this, were to come up to me and smile, my pupils would dilate some, again, with no conscious thought about anything. Now, these areas of the brain connect to the prefrontal cortex, which is a area of higher learning, as opposed to the deeper structures we talked about earlier, which you might consider to be the lizard brain. This is an area of humanization or so. And it is involved with, it is basically what Sigmund Freud referred to as the superego, the conscience. This is where you think, lead you to think about consequences of your actions, the need to think about the future, and would suppress some of the primitive urges. So this is the area of the brain that would keep me from reaching out to grab either that plate of food or the woman and therefore, at least in some borderline capacity, be able to function in a society. Okay. So let's look at each of these areas. We'll start with the nucleus accumbens. So the nucleus accumbens is the pleasure center of the brain. Dopamine release at this area of the brain gives you a sensation of pleasure. This is what lets us enjoy anything that happens. So that would be fine. But then there is, however, question: what happens with repeated exposures? And I would ask you this question again. Feel free to chat in any answers, but what the question would be is, if you have something pleasurable in front of you, such as a piece of chocolate cake, which bite of that chocolate cake is going to give you the most pleasure? The first bite or bites afterwards? So, yeah. And I think most people would say that it is the first bite. That is the bite that would give you the most enjoyment. And that is what's called a negative. That's because there's what's called a negative feedback loop here, where more exposure to the same stimulus gives you less dopamine, less dopamine and such. So, and so you get less and less pleasure with subsequent exposures to anything. And you think about that, that's necessary for learning. It says what we learn is something is good or bad based on whether it increases or decreases our dopamine level. But once we've got that, it's not efficient to keep hammering at it. So your brain, which is interested in your survival here, or interested overall in survival, will decrease the amount of reinforcement with time. Now, I should have mentioned earlier, let me just say that now, when you think about dopamine in the brain here, drugs of addiction do what's sometimes referred to as hijacking this reward system. The surges of dopamine you get from drugs of addiction is much more than what you get with any natural stimulus, more than twice as much as so. So it really amplifies and distorts this reward system. And here you get that too, where it amplifies and distorts this to where what we see is that you can't recreate the tremendous dopamine surge that happens with early use of this. And what happens with that then is the phenomenon of tolerance, where you're having to increase your dose to try to get the same effect, what sometimes people refer to as chasing the dragon. That would be okay, but you find with your dose going up. But what happens with this is you really deplete your dopamine receptors in this area, and you're not able to respond to what should be normal stimuli that make you feel good. Any normal thing that gives you the reward of pleasure is not unable to do that because it doesn't have the ability to make dopamine with any amount from that. And more than that, you find that your baseline level of dopamine drops. So where just feeling at baseline instead of feeling neutral, you feel bad. So eventually you're trying to get back to a level of just feeling decent rather than feeling good. So trying to feel normal. So you go from feeling normal, trying to feel good, to feeling bad, trying to feel normal. And this demonstrates some about those dopamine receptors. And if you see red being hot and going down the scale to orange, yellow, green, and blue being the least activity, you can see the effect of depletion of dopamine receptors with use of the drugs, with normal control being on the left and then the drug use on the right. Okay. So I say with time, you don't feel much good from it, but without it, you feel very bad. Now let's move to the ventral tegmental area. And while the nucleus accumbens had to do with liking something, whatever stimulates dopamine, the ventral tegmental area has to do with wanting whatever stimulates the dopamine. And it's important to recognize that wanting is not the same as liking. They're really quite different. So this is about desire. So dopamine release here makes you want something. Now a question for you. We'll go back to that piece of chocolate cake. You may like that first piece the most, but which piece do you want the most? That first piece? Well, which piece is it harder to resist taking? Is it easier to resist the first piece or easier to resist later pieces, the second piece of chocolate cake? Well, if you're like most, I think you'll say if you're not going to have it in it, you're better off not have it in it. You take that first bite, it's really hard not to take that second bite. This is that positive feedback. And if any of you all happen to be old like me, which you're probably not anyone else there that remembers this was an old commercial where Lay's potato chips took advantage of this naturally to say, bet you can't eat just one, taking advantage of the fact that second and third ones are harder to resist than the first one. So this is a positive feedback loop where the substance that's causing the release of dopamine causes more dopamine release in the VTA with subsequent use. So that means that while you're increasing your dose to try to get back to some pleasure by way of dopamine release nucleocumbins, you're having more and more drive to use with the higher doses at the VTA. And this is what creates compulsive drive to use. So this is really the core of addiction, the cravings that develop where you're willing to have negative consequences to seek out the drug, and you have an unrelenting drive to get and use the drug. So again, while you like it less and less, you're craving or wanting it more and more. Now, there is a connection, however, to the higher center of the brain. This is the cortex, the gray matter, the humanizing area of the brain, and the prefrontal cortex. So prefrontal cortex is responsible for what we call executive area, which include planning for the future, delaying present gratification for future gain, thinking about consequences of others, and also that inhibition of primitive urges. Well, not surprisingly, what I'm saying is that these drugs of addiction have a negative suppression effect on the prefrontal cortex. This really ends up being very important because it means that you're not able to think as much about the consequences of your actions. And so it's not the consequences of stealing your sister-in-law's credit card, neglecting obligations and responsibilities, and because the drive to use drugs is so strong and things, so it means like missing graduation of your kids because of drug problems and such. All these have their source in the prefrontal cortex. And this is showing some of the cortical activity, more than the prefrontal cortex, of course, but mostly that if you look prefrontal, of course, means prefrontal, which is the top here, the front of the brain. And you can see how somebody who's had use of cocaine within 10 days has quite a bit of shutdown of cortical activity. And there is some recovery when they go 100 days without use. You see down the bottom. So with time, you do think this can correct. You can see that it is dramatic shutdown of the prefrontal cortex. So that means that you think that you have less ability to suppress your actions and despite things not doing well. Now, let me stop here for a moment and let's talk about sex. And that's because I want to wake you guys up a little bit. And also because the sex drive really involves a reward pathway. And it involves it in a way that we can say that when it comes down to it, this pathway isn't really interested in keeping you alive and well. Often the individual survival goes along with it. But what the reward pathway is really interested in is preserving your genes. And that shows up with sex drive because people will find this system activated and may do things that are not in their best interest, the interest of the survival of the individual. If you think about it, this drive is a drive to have intimate contact, to have more and more touching of another person. Well, that makes no sense at all from a survival standpoint. But we do find dopamine secretion at the VTA making it more and more. So a little bit of physical contact or the possibility of physical contact, and the normal response is to want more and more of it. And even if you take it to extremes, but still normal, be willing to take risk, to not think about the consequences of the future, all this because of suppression of the prefrontal area of the brain, in order to have that contact. So people will can take a real risk for this, even though it has no advantage for survival of the individual. Well, you think about that as normal, and one that you'll put yourself at risk, but it's still very normal. And remember that drugs of addiction amplify and distort. They really hijack that system. So you increase that dramatically, and you can see what happens with the drugs of addiction or so. And it ends up in a situation, I think, that must have inspired Mr. Romero when he came up with the idea of zombies from Night of the Living Dead. Because when you look at how we describe zombies, you don't see that they have any great pleasure in brains anymore. Maybe they were good at first, but they have a real strong drive to use brains, to get brains, and they certainly will put themselves at significant risk in order to get them. So I think he must have been thinking about addiction at the time he came up with that. Okay, so all that may be a little depressing to talk about, all that drive and such. The good news is there is a cavalry that comes, there is treatment. So now I want to shift gears a little bit and talk about buprenorphine, which is trade name Suboxone, and how it actually does treat addiction, as opposed to what many people have thought about it and how it interacts with the nature of addiction. So to do so, I want to start with this gentleman. This is a newspaper article from several years ago when I was in Kentucky, and it is a negative article. If you know, been around enough to see newspapers, when something new comes along, they'll very often put an article about how promising it is. But then later on, they'll follow that with an article about, well, maybe there's problems with this new treatment or so. And this was that negative article where they started trying to say what might be problems with using Suboxone. And here's what their star, Mr. Starnes, said, looking at the bottom part particularly about this. He said, the first few times I used it, I could get really high from it. Now, I need to stop and explain something here for a moment that we'll come back to. But the way that either methadone or Suboxone or Suboxone work is by giving you some level of opioid, but and making that opioid level enough to keep you from having any cravings. In other words, to suppress the VTA, so you don't get ongoing urge to use. But you should know that how you feel doesn't depend on how much opioid's in your system. It depends on whether your opioid level is going up or down. It goes up, you feel it. It goes down, you feel the absence of it, withdrawal and cravings and such. It doesn't depend on whether there is opioid in your system or not. You might relate this to the aroma of cooking in a house. So if you're in there cooking and somebody comes into the house, they may say, boy, that smells good. What is it? Well, you have not been aware of any aroma. Of course, if I'm the one cooking, they might come in and say, what is burning? But same difference, you get used to the aroma, you don't feel that. And that's what happens here. You don't actually feel your level, you feel ups and downs. So what you see, he first could feel the effect of the drug. I'd get really high from it. Of course, he was injecting this thing. But then he says, then I just felt normal. Now, by normal, you think that means not feeling that compulsive drive to use, not feeling the absence of withdrawal, and also not feeling high, not feeling the sedation and effect of it that would interfere with function too, even if it was pleasant. So he wasn't high, but he wasn't sick either. It says, then to me, it is just trading one addiction for another. So we're going to look back and say, is that right? Is what he's describing trading one addiction for another? And what I ask here then of you is, when he is taking his Suboxone, is he showing any sign of addiction? So back to our definition of addiction: compulsive drug seeking and use despite harmful consequences. So I'd say the answer to that is no, really. He really wasn't feeling that. He felt normal. He wasn't high, he wasn't feeling sick, and he wasn't having any drive to use. So what he's describing is not addiction. So what do we call it when you have a condition and treatment leads to no sign of that condition. When you think about cancer treatment or so, that would be what we would call remission, right? So actually, Suboxone treatment, when successful, induces a remission in the chronic disease of addiction. So the point here, and this gets to be an important point I want to go to, this is really one of the keys where people understand the medication and not be reluctant to take it. Again, it comes down again to, is addiction a character weakness or is it a disease? And we say that our knowledge that we just talked about with our rewards pathway and such is that it is a disease and such. And so it has to do with this disease with behavior. It's not use of the drug alone that makes you have addiction. Addiction is more than just using a drug or so. And to illustrate that, I want to talk about a couple of times. One is when a patient is no longer using a drug, but I would say still it has addiction. And the other one is someone, our patients, who take drugs and show no sign of addiction. So back to the first one, where there's no drug use, but we still have the behavior of addiction, the compulsive drive to use despite harmful circumstances or consequences. So you think about, when would there be a situation where someone who has an opioid use disorder cannot use their drug? And there's two relatively common times to think about. One is if they're in inpatient rehab where they have voluntarily gone into treatment and did not have access to their drug. And the second would be incarceration, where they don't have, at least most of the time, don't have access to their drug. So they're not using. So in a situation, maybe for long periods of time in jail, they are not using the drug. If it is just the drug, if it's just drug use is the problem, therefore addiction should go away, right? And we do see the physical things with addiction go away. You know, you no longer have it in your drugs, in your systems, you don't have the sedation and so forth. And you lose your tolerance, you know, the amount of drug it takes to have an effect. So the next question, what happens when this person who's not been using for months or even years in jail gets out of jail? What happens then? Well, what I would say is the addiction may very well and almost always is still present. And the result of that, we see, is a real immediate increase in the risk of overdose. In the first 2 weeks, you can see it is dramatically higher than it is 5 to 6 weeks later on after they're back in life. And that's because while they're not using, the addiction is still there. They still had a compulsive drive to use. And that may have been suppressed some while they were in jail because they didn't have triggers. But when they got out and those triggers were there, almost immediately can be a relapse right away. Okay? So that's a sign that it is something that happens in the brain, and it's not simply the effect, the drug that's going on. So now let's take the other situation, which is somebody who is using a drug and has no sign of their addiction. And that's, I would say, that the patients I see in the office all the time. That's the patient that's on Suboxone. And to give you an example of that, my nurse's name is Jay, and almost every time clinic, we'll have a patient say, who's scheduled 10 a.m., John Smith. And it gets to be 9:58 and John's not there. So Jay gets on the phone and calls up and says, John, how you doing? Where are you? You have an appointment at 10. And John says, Jay, oh my God, I completely forgot and I overslept and I am out of medication today. What am I going to do? And so Jay will say, well, come on in. We'll see when you get here. Well, obviously that really plays havoc with my schedule and people showing up, missing their appointment and showing up late. But think about that, what that means from the point of view of addiction, because I guarantee you there has never been a person with heroin addiction actively using heroin who runs out of their medicine and forgets about what arrangements they've made to get more. On the contrary, addiction results in a continual cycle of how do I get my drug, making arrangements to get it and using it, and then again, how do I get my drug, and it dominates your life. And these people, just like me taking my cholesterol medicine, no particular drive to use. You have to remember that you're going to run out. You need to get more. There is no compulsive drive to use. And so that is remission. And that is what buprenorphine can do. They put the disease itself into remission. Now, however, we look back at Kenny Starnes, that wasn't good enough for Mr. Starnes. He wanted to be able to take something and obliterate that drive to use. He wanted a cure. And I certainly can sympathize with that. I would love to be able to offer him a cure. I would love to also be able to offer a cure for patients with rheumatoid arthritis, gout, heart disease, diabetes, high blood pressure. But that's not the nature of treatment of chronic disease in the year 2021. We do not have many cures for chronic diseases. And addiction is no different than any other chronic disease. If you look at this graph, what it's showing is that you have hypertension and you stop taking your blood pressure medicine. A good deal of them, the vast majority of people, will have a relapse to high blood pressure. And that's equally true for addiction. At any time during treatment, if someone stops taking their maintenance treatment, Suboxone or methadone, they have a very high risk of relapsing. And people will look at that and they go, well, you mean you have to keep taking the drug for a long time? Yes, that is the nature of chronic disease. And we'd like for all chronic diseases to be able to be fixed, but we're just not able to do that. So treatment and putting the condition into relapse is pretty much the best we can do with things. Okay. All right, so I haven't really said anything about what buprenorphine is, and I want to make this relatively brief because you only don't need to know, of course, all the details about it. But I've already explained that the long duration of action is the key to how they work. And that's, of course, maintaining some opioid level. What we need to know about buprenorphine is, first of all, it is what we call a partial opioid agonist, partial antagonist. Maybe more familiar with the word antagonist, something that works against something. Agonist is something that works the way something else does. So it's an opioid agonist, mean work like an opioid. And as an antagonist, mean work against opioid. So it's kind of in between, really. It depends on where you start. If you start with no opioid, it will raise your opioid level and you will feel some opioid effect. If you start, however, with a significant level of opioid in your system, it will bring that level down and you may even feel withdrawal. If I can digress.
I'm sorry, John, to interrupt. We've got about 5 minutes.
Okay, so let me move along here. I was just going to say that it therefore can have that. It can have either effect depending on where you start. Now, the key to it here, when you look at it, there's 3 things about buprenorphine to remember. And one is that long duration of action, which is really how it works. And the second is that low opioid activity, and that is a very small amount of opioid. And third is the high affinity for opioid receptors. It means that receptors really like the opioids. So I'm just going to skip to say that what happens with that is, by way of its long duration of action, it maintains enough level to keep people feeling normal. But because it has so little activity, you can give what's relatively a lot of this drug and really saturate the opioid receptors as compared to the much more powerful drugs like morphine or heroin that leave a lot of space where you can add more opioid on top of it. You can't do that with buprenorphine because there's no receptors left to put the drug on. So it blocks any further opioids from taking effect. Now you might say, well, can't they just take heroin, replace the buprenorphine? It can't because of the higher affinity for buprenorphine. In other words, the receptors prefer buprenorphine. It fits them better and it is not easily displaced. So that's really the way that it works and such. So I'm going to skip ahead because I wanted to get to an important part here and skip. That's basically an outline of how it works. And now I'm going to skip. I wanted to talk a bit with you about some situations with it. And you all know the effect on the patients. You know this, and let me just mention here that when I talk about effect on family and friends, you all, I'm sure, deal with ACEs all the time. And I'd like you to think about how many of those adverse childhood experiences had to do with substance use. Okay. And you know, in the community, that's a lot of the problems we have there. Now, what I wanted to mention to you is the stigma, because this is important. Now, I wanted to talk about some situations where if you think of addiction as you should as a disease, your treatment will be different than if you think of it as a character defect. And so that's our third sidebar when we talk about the stigma and such. Okay, so we mentioned a couple of things. One is now the biggest stigma is getting people to come into treatment at all, to start their treatment, to come in, because there's so much negative thoughts about I shouldn't be using medication. But let me just mention, what about someone who comes in to see me and then they come back the next week and say, I did great with my Suboxone. I didn't have withdrawal. I'm not feeling a drive to use. But my family says I should stop taking it now because, after all, I'm only substituting one addiction for another. So what happens if you stop this really early? Oh, I'm sorry. I wanted to mention well, I'll just skip this for now because we're short of time. But here's what happens. If this is take 40 people, 20 of whom had Suboxone treatment in addition to behavioral health, and 20 of whom only had behavioral health. And you'll see over a year, the ones that continued, they all went through withdrawal. They'd all had no patients were withdrawal that started this. They've been treated for that. And now they were treated with buprenorphine and Suboxone chronically. And you see, after a year, 15 now to 20, we're still doing very well with not using heroin and getting along well. While as the other group, 16 out of that 20 dropped out of treatment in the first 2 weeks, and all of them dropped out by about 2 months. So it's saying you can't just do it for a short time. And what this slide doesn't show you is that 4 of those 20 were dead by the end of a year. The next thing I mentioned, as far as the stigma of as a patient who then comes back and says, I'm doing very well with my opioid addiction, but I can't stop using cocaine. I still find myself having a drive to use. And what we'll see, what a lot of people say is, well, they're not doing well, then you need to stop treating their Suboxone because their addiction still gives you trouble. But if you think about it as a disease, you'll realize that those are very different. There's no reason to think that Suboxone, which is an opioid receptor drug, would do anything for cocaine. And we would never do this with other illnesses. If we have somebody who has asthma who comes back with allergic rhinitis, we'd never say, well, you get to stop your asthma treatment. But if you think of this as a character weakness, you may say they still have addiction. You're not getting anything. They just want their Suboxone. But that's thinking that Suboxone is something that people have a drive to use, and they don't. And thinking that all addictions are the same. And again, like all chronic diseases, it's not. And so I think that just illustrates the stigma. And once you think about it as a disease, you don't have that. And the other thing just to mention is a person who themselves has stigma about it. Most patients with addiction, their self-esteem is hurting, and they will think that they shouldn't be doing things, including often shouldn't be taking Suboxone like it's some kind of failure. We have to work through that. So we have a patient who a year later runs out of the Suboxone and relapses, and that certainly happens. They may think, this is not working for me. I just am an addict and I'll always be an addict, and this isn't changing that. Well, as again, somebody with asthma who stops their medicine and relapse is not going to think that. They're going to think, there's a sign I need to continue treatment. So saying we need to get through the barrier of thinking about it as a weakness and more thinking about it as a disease. Okay, so I'm going to basically stop there because you all are really going to enjoy David Douglas's talk and get a lot out of that. So just mention, that it can be anyone that gets addiction. It is a biologic illness that can happen to anybody, more common in certain circumstances, including family history, but can happen to anybody. So again, thinking about it not as something a character weakness or moral failing of the person, but as a disease they need to treat. So as a quick summary to say, addiction is a chronic relapsing brain disease characterized by compulsive seeking of a drug despite harmful consequences. It's not a character weakness. We have very well defined mechanism for this disease in the brain involving the effect of dopamine on certain centers, the reward pathway of the brain. We also have medicines that can make a difference, and these medications are treatments for the disease, not substituting one drug for another. And the one that's most available to us is buprenorphine or Suboxone because of the safety of that drug that allows us to use it through an office practice rather than out of a methadone treatment center where they distribute one day at a time. So you all who are seeing people with addictions, won't you understand what they're dealing with, the disease that they have, and understand there is very effective medication treatment for their opioid use disorder. Encourage them to get Narcan, as we're saying, because that can be life-saving until they get good treatment, and to seek out treatment, which would include seeing medical personnel to take Suboxone as the best treatment here locally. So if we could do that, we can make a real difference with the opioid use disorder here in Ellensburg. Okay, so I will now turn this over to David Douglas, and you all will get a lot out of his talk, and I will still be here so I can try to answer any questions that come after his presentation. Thanks for your attention.
That was great, John. Thank you. And for those that are watching, if you may not know this, John and I have wanted to do what we're doing today, I think, for at least about a year. So this is our first time doing this presentation tag team. And I love how John presents what can be to some dry information, or in some, when he talks about morality, is a disease or not a disease, he presents it in a real digestible way. And so I always appreciate how you present it, John, and the work that you're doing in our community is good. So, and just so everyone knows, I'm definitely going to leave about 10 minutes for questions. So if you have questions about John's and or mine's or both of ours, I'm going to leave some time for questions. So if you're like me and I had my video off, I hope you've had some time to move around and stretch and do all that. If we were doing this, we'd take a small break, but for purposes of time, I'm going to dive right into this. And some of you in the room have seen my talk on the history of the drug war. I looked through the names and there were some unfamiliar names. So if you haven't, you're going to get kind of a sandwiched presentation on that. And then I'm going to talk about what John has already talked about. And that is the reality that there's a ton of stigma surrounding the arena of substance use disorders. And there's not only stigma around an individual, feeling shame or fear about asking for help. There's also stigma for people in long-term recovery. And I won't have enough time to talk about the real in-depth issues, barriers there, but I'm going to give you some tools as providers, as healthcare providers, as professionals on how to use person-centered language in this arena. So this is a brief history of the drug war, and then some skills to lower stigma surrounding substance use disorders. And just briefly, Pam gave that introduction. I am Dr. D. Students know me that on campus, and I've done research in this arena about pathways to recovery. And I always like to say this: there is no one way to get to and or stay in recovery. What John presented is a very powerful way for people with opioid use disorders to find their path to recovery, and it should be accepted and given as a way. And there are other ways for other substances. What we need to do as a community is allow individuals to find their path that works for them. The one size fits all method of treatment and recovery must die, right? That's kind of a myth that there's only one way to get to and stay in recovery. So that's part of the work that I'm doing in the community, is to help. I like to say I'm kind of a myth buster in many ways. So it's good to be here. It's good to virtually see everyone. I personally am encouraged. I think we're really, the vaccine's out. In fact, I think today my in-laws who are in that high risk category, they're getting their vaccine. My wife, who is now a teacher, she's getting up. So I'm encouraged. I think that we're really going to start climbing out of this. And I say that because I like being in person doing these. This is great. I'm adaptable, but I can't wait to get back in person. So let's do a little history lesson. And this history lesson that I give is all about helping people understand the why. And the why what? What are you talking about with the why? Well, the why is what I've learned is, why have we in our society treated this health condition, a substance use disorder, through the criminal justice system? And I like to give a story, and this helps you understand how we treat this health condition to this day like a criminal justice issue. So the story is this. If an individual, and I have lived experience, okay, I'm a person in long-term recovery because of access to treatment and resources. I have an amazing life today. I've been to treatment twice. I've been to tons of counseling. I've been to physicians. I've been treated for depression and anxiety and those ACEs that John was talking about. I hit every one of those markers. Because of access to resources, continued access, I live an amazing life. Yet the onset of my treatment was through the criminal justice system. So let me give you an example that could happen right here in our community. An individual with an active substance use disorder, active addiction, is in the community. And as John pointed to, for many people with addiction, they commit what are primarily low-level, non-violent crimes to feed that addiction. So, and I'm not arguing that we shouldn't hold people accountable, not at all. If someone breaks the law, they need to be held accountable. Absolutely. This is just an example of how we right now today in our society treat this health condition primarily through the criminal justice system. And people get instant access to resources through the criminal justice system. But when they say, hey, I need some help, they don't always get instant access to those same resources through the healthcare system. So Johnny, let's just call this mythical figure Johnny. He is in active addiction and he commits a crime, say at our mall. I jokingly say Fred Meyer's our mall, right? Because that's our biggest store. And he gets arrested, and it's at a dollar amount where the police come and they say, oh, wow, okay, this is not good. So you're going to jail. To keep this short, he gets instant access to resources, right? Tax dollars, taxpayer funded resources in our community. And he gets taken to the Kittitas County Jail. No one would argue that that probably should happen like that. That happens for a lot of people in active addiction repeatedly, right? Now there's change that's happening, and it's good. In fact, our county is, I believe, a leader that there's change happening, meaning that if Johnny does go to jail, there's a pretty good chance he might get asked, do you need help for your substance use disorder? It has not been like that, and it's not always like that. Now, so Johnny gets out of jail because they don't have room in jails for low-level nonviolent offenders. He gets out of jail, and so that happens repeatedly, right? Let's say Johnny, on one of those trips out of jail, he, because of family or his own, epiphany, whatever the case may be, he says, I want help. Well, so Johnny goes to the local treatment organization, and I know in our county, we're fortunate. They do day of assessments. An individual can walk in, they'll get an assessment right there on the spot. In fact, right now in our county, the cool thing about Kittitas County is they're actually doing assessments in jail, which is great. But here's the tough part, is getting a bed for treatment. Likely what happens, because Johnny probably doesn't have great health insurance, or he doesn't have health insurance at all, and or we have an issue with treatment, inpatient treatment beds, Johnny's probably going to get told to wait. A lot of times, not because maybe there's not a bed, but because he doesn't have cash money to pay for treatment or insurance. So state beds are not as plentiful as if you had, right, cash money and you could be flown across the country. So he gets told to wait. What's going to happen with Johnny? And I'm going to look at my watch a little more during this presentation because I know I need to get through these slides a little quicker than normal. So excuse me if you see me doing that. So Johnny goes to the treatment organization. He gets an assessment. And what happens? He gets told to wait. And those of you that work in the field, you see me laugh, and I laugh because, wait a second, what's Johnny going to do who has an active substance use disorder, needs treatment, needs access to a physician, needs access to help for that condition? He gets told to wait. Well, I'm going to tell you what Johnny's going to do. He's probably going to continue use, right? And then what's going to happen? Johnny's probably going to commit another low-level nonviolent crime and probably be in contact with that same officer that comes and says, "Oh, it's you, Johnny." And what happens? Johnny gets instant access to resources again and again and again through the criminal justice system. But our system, because of the drug war, has created a system where people get instant access to the criminal justice system, but not the healthcare system to treat what really needs to be treated, which is the substance use disorder. So going way back on this slide that you see on your screen that you've probably already read, we were moving toward a healthcare approach way back when in the 40s to the 60s-ish, through leaders in this field. Really, the founder of the National Council on Alcoholism and Drug Dependence, the NCADD, Marty Mann, she was a person in recovery herself. She testified before Congress, and sorry, I'm not ready to go to that one. And there were things going on in very positive ways. We had legislators saying, yeah, we need to help people, because if you go way back in the 40s, prior to this being identified by the American Medical Association, where they added alcoholism as a medical condition, if someone had a drug or alcohol problem, they were sent to a sanitarium, right? A mental health hospital, and just like nothing happened. They died. It was just crazy what would happen. So people started saying, no, we need to start treating this like a health condition. We need to get people help. So good things were happening, right? And always keep in mind that the American Medical Association has defined this as a medical condition since 1952. There was a shift. And that shift was the pivotal moment during the Nixon administration. You can YouTube it yourself, his historical speech where he began the drug war. He declared drugs enemy number one. And that's when you saw funding shift dramatically. Now, all of the movement and the funding that was going toward treating this like the health condition that it is stopped. The well ran dry, and all of the money went to law enforcement, to the judicial system, because the Nixon administration began the drug war. Now, I was fascinated when I did the research and learned about this. This was also during the height of the civil rights movement. The drug war, if you read about this, was really just a way to continue racist overtones toward our African-American low-income communities, because those communities and those families became the target of the drug war. Now it's bled over into all demographics, but those communities were the target of the drug war. Fascinating. And again, for purposes of the time, we go into the 70s, and then the 80s, okay, is when a couple terms started coming into play and that are common terms now. And those were, one of the terms is mass incarceration. So we had the crack epidemic of the mid 80s. And that in some of you in the age group, my age group, I remember this period of time, and we saw it all over TV. Where was the target of the drug war during that time, during the crack epidemic? Well, it was in low-income communities with primarily African Americans. And here's the thing, here's another story for you during this period of time, because this is a time where the judicial system, as a result of the federal government's laws changing during different administration, started putting in place draconian sentencing laws, like life sentences for having minuscule amounts of drugs. So here's what happened during the crack epidemic. If an individual was caught by a law enforcement officer with a very small amount of cocaine, crack cocaine is cocaine that is cooked. And a rock of crack cocaine is a minuscule amount of cocaine. But the mandatory sentencing laws, which tied the hands of judges, because judges are supposed to be judges. They're supposed to make the best decision on each case, blah, blah, blah. They couldn't even do that because they were required, if an individual was caught with, say, 5 rocks of crack cocaine, they were giving mandatory sentences of 5, 10, 15, 20, 25 years. And in some cases, if they had more, life sentences for small amounts of cocaine. And some would say, well, yeah, if they're dealing it, that's what should happen. Well, okay, fine. But let me show you this example, the story. If an individual was caught with a bag of powder cocaine that usually higher economic and Caucasian families had, powder cocaine, if they had that, they were not given life sentences for that. This amount was minuscule. This is a massive amount of cocaine. So you saw this ramping up, and the term mass incarceration came into play. It came into play in the mid-'80s, where we, the industrial society, right now to this day, we imprison per capita more people than any other industrialized society. And the vast majority of people that are in prison are the result of the drug war. Low-level, nonviolent offenders who probably needed treatment, not jail. But that's what they got. And during this period, it's just been in the last 15, 20 years that we've started going, yeah, this isn't working, right? We can't arrest our way out of this problem. Most law enforcement officials that have been in the industry for any amount of time, they even go, yeah, we can't keep doing it like this because this isn't working. But prior to that, we were just housing people in prisons. They weren't getting rehabilitation. They weren't getting treatment. So if they did get out, the cycle just repeated itself ad infinitum. Now, so imagine the stigma. If you wanted help, number one, you couldn't get it, but the help you got was directly through the criminal justice system. And the stigma surrounding substance use disorders during this period, and even to this day, there's a lot of shame and a lot of guilt put on people who want help for this health condition, but many people think it's a moralistic issue. And well, if they just made better choices. John, I'm glad we've done this presentation. I'm hopeful to do more, but he just gave you the biology of the disease. It's not a moralistic failing. It's someone needs help. So mass incarceration that we all are familiar with. I do want to say I was excited to see President Biden sign an executive order to start phasing out the private prison complex. And I'll just say this, and this is my view on it, is should we have private for-profit companies running prisons? Isn't prison and incarceration all about rehabilitating people and hoping that they can get back into society? My issue has always been, well, if it's a for-profit private company, well, I have 2 businesses in the community and they're for-profits. I want more customers. I don't want less. So that's always been my struggle. So it's good to see. And that's just one thing. We're seeing a lot of movement toward helping people. If they are going to be in jail, like our county's doing, let's help them try to find the treatment they need and the help they need so they can stop going to jail. So the tide begins to shift. And this was in the 90s as a result of the meth epidemic. That's when we really started seeing, and for me, drugs have been part of our society. Oh, the drug war, sorry. How has the drug war failed? You might be saying, this guy's saying the drug war's failed. Well, if you look at it from an economic standpoint, or the goal of the drug war, which the goal was to do what? Get drugs off the street. We have the same amount, if not more, drugs on the streets now than we did when the drug war started. So if you just look at it from that standpoint, it's failed. But from a human standpoint, the drug war has never been a war on drugs. It's always been a war on humans and families. So in the 90s, judges and courts and law enforcement officials and lawmakers finally started going, yeah, this isn't working. So drug courts began to form during the meth epidemic. Let's try to help people. I didn't go through drug court specifically, but personally, my lived experience is I'm from Pierce County originally. And when I first found a path to recovery, it was through the judicial system. And I went through something similar to a drug court that said, hey, let's get you some help. Let's get you on a track of recovery. So I was provided resources. Leaders in law enforcement really just started saying, yeah, this is not working. So the federal government started ever so slowly during this time period to go back to the 40s and 60s and treating it like the health condition that it is. I'm doing good on time. All right. So we moved back toward, sorry, it's kind of a delay on my end when I change slides. We started moving back towards a healthcare approach for substance use disorders. And recovery advocates started slowly speaking loudly about the need for change. Again, I'm a recovery advocate, and I'm a bit of an anomaly, even in our county. I have many friends and people that I work with that I know are in recovery, but they don't talk about it. They keep it quiet because of the shame and the stigma surrounding it. It is my goal to speak loudly about the power of people in recovery so that we can shift this narrative from being this criminal justice issue to a healthcare issue. So myself and many others have started speaking loudly about the need for change. And we all know as citizens that when we speak loudly and when we band together, we can affect true change. So there are now groups, organizations that lobby states and federal lawmakers to shift this narrative from that criminal justice approach to the healthcare approach. And it's all started with small grassroots type efforts and organizations, individuals that turn into communities and then states and other organizations that grow into maturity and are really starting to make change. So the stigma is now you don't have to go really far to start learning. Yeah, there's a lot of stigma surrounding this healthcare issue that I, as a professional, can start learning about the history, like I've just given you, and ways that I can shift the narrative here. And I always like to say, just remember, you're dealing with humans. You're dealing with a life, and you're not dealing just with one life. You're dealing with that individual's life and a whole family's life. And I'm going to ask a question because I'm shifting gears. I've got about 10 minutes, so I'm doing pretty good. This is the time when I talk fast that it works well. So I'm going to shift gears and I'm going to talk about the use and really, for me, the mindset shift around this healthcare issue and using non-stigmatizing language. And what I want to ask, and just because we're rolling with this, if you want to put it in the chat, okay, I want to ask, what are descriptors you think of when you hear the terms that are pretty common when talking about substance use disorder? If you hear the term addict, what image comes up in your mind? You can just write it in the chat. I'll look at it when I get done with the presentation. Or alcoholic, right? What image of an individual or what scene might come up in your mind? The term clean and dirty, right? Which when I even see that on the screen, clean and dirty, which is used to describe people and or behaviors, habit or drug habit, abuser, just that negative term alone. Generally speaking, they're not positive images that come in mind. But what happens all too often is these are some of the most common terms used to describe people who have a substance use disorder. I personally and professionally made a decision, it's been about a decade ago, to not use these descriptors in any of the language I use to talk about myself and or others. You won't hear me, you didn't hear me when I started this talk say, my name is David and I'm an addict, or my name is David and I'm an alcoholic. And I say this because there are mutual aid groups, support groups, AA, NA, there's other anonymous type groups where maybe if I choose to go to a setting and I choose to use that descriptor for myself in that setting, that might be okay. I actually go a step further. I choose to not use these descriptors to describe myself or others. So if I'm out in the community, I lead with, my name's Dr. Douglas or David Douglas. And I talk about the positive side of recovery and the positive side of my life. And then I might share a little bit of my story, but I don't lead with negative descriptors. I always like to say words matter. Language does matter. Think about if someone pronounces your name wrong. Now, I have an easy name, right? David, but I teach at Central and I have students from across different nationalities and ethnicities. And I always like to say, help me pronounce your name. But think about the last time someone pronounced your name wrong. Did you correct them? Or a step further, if someone pronounces your child's names wrong, I guarantee you probably correct them. You go, no, that his or her name is this, right? So think about that. And I always say with this, why is it that this is the only medical condition that is described in such negative ways, that is viewed in some really, really sad negative ways, right? People get really fired up about this health condition. But when you think about other health conditions, you don't see, even diabetes, right? If someone goes into their doctor and they, say, hey, you know what, I need some help with my diabetes, we generally are going to try to help them, and we don't view them or talk about them or describe them with these real negative descriptors. Same thing with cancer, right? We wrap our arms lovingly around people with cancer almost immediately. But yet with this condition, we have these negative views and negative connotations almost immediately right out of the gate. We stigmatize, we moralize, we judge, instead of doing the same thing we do with other health conditions. So there are things you can do. And the overall reach is using person-centered language. Okay, so I gave those descriptors that we're all familiar with: addict, alcoholic, abuser, junkie. And I don't, I'm an educator, so it's part of my job. I like to help people use positive language. Substance use disorder, that's the medical term. That's what I use. I don't even use substance abuse. I use substance use disorder. That's a medical term. That's neutral language. It doesn't lay any judgment on anyone. So person with a substance use disorder or person in recovery. My name's David. I'm a person in long-term recovery. Because of access to resources and treatment and doctors and education, I haven't had to use any drug or alcohol since March 25th of 2007. So that's how I introduce myself. Imagine a different use. My name is David and I'm an addict. Immediately, if an individual has no education or no knowledge, they're going to have a pretty negative view of me, or at least not as positive a one as the one I described using just neutral and positive language to describe myself. Dirty or clean. And it's like, oh man, I was never dirty. I was a human surviving, right? It's not a matter of dirty and clean. A person in recovery. Relapse, chronic relapse. You won't hear me use those terms. I use return to use. Again, because of the stigma and the negative connotations with both of those terms, it's return to use. And at the bottom, I've said this a couple times and I'm almost done, and we're going to open it up for questions on my presentation or John's habit, drug, alcohol habit, substance use disorder. So there's some really simple things that you can do as a practitioner, as a provider. And I'm happy to send this out. It's a really simple graph you can use, and it's a mind shift. And I think my psychology side that I really always have to catch myself. I have an amazing life as a person in recovery, and I need to be really careful when I see someone on the streets or I hear about someone who's struggling and go, man, boy, maybe they just don't want it. No. stop it. I needed treatment multiple times. I needed access to resources multiple times. And look at my amazing life. I think of my son. I think of my wife, a person in recovery, because the reality is we are worth the effort. That picture on the left, I don't live in my past, but it's a good image to show, because now you've learned a little bit about me and the amazing things I get to do in our community as a person in recovery. And when we help one person, we don't just help one person, because we help a whole family. I'm a member of a family of people in recovery because of access to resources like the MAT program John provides, or inpatient treatment, or mental health counseling, or a physician who understands depression, ACEs, and anxiety, and can help with medication in those areas, exercise, education, all of those resources. Myself and my family members and our peripheral friends, who I have friends in recovery, we don't just affect one person in hugely positive ways. We help families and we help communities. So I'm going to stop sharing, and then we are going to open it up for questions.
So feel free to put your questions in the chat, or just if you want to unmute yourself and ask either David or John a question.
Pam, Lucy, I'm having some video trouble. I'm not seeing slides, and I'm also seem to not be seeing the chat boxes there. So if you can relay any questions that come there to me, it'd be great. But anybody wants to speak up, that would be fabulous also.
Hey, Dr. Asriel, and David, thanks again for presenting today. It looks like you'd answered my question, Dr. Asriel, about the buprenorphine. And, thinking of this as a chronic disease, there's been a lot of look at using polypills for, say, cardiovascular disease, combining statins and ACEs and trying to get one pill for convenience. Do you think addiction medicine is going to go that route, trying to have one pill to help?
Well, I think we probably are limited that we have different pathways for different drugs. All of them have at their kind of the end effect, the dopamine things I talked about, but how they get there is different. When we talk about opium, where we're looking at opioid receptors, we don't have great treatments at this point for other addictions medically. There are things we try for other drugs. We have pretty good ones for alcohol and tobacco that work on nicotine blockers or different effects there and work on the alcohol system. But I think that we look at the final pathway of dopamine. There may be something at some place there people are looking at, but I don't think we'll be looking at combination of things as much unless it is looking at trying to help with the other things that occur, other symptoms that come along with it. Let me mention, just to put a little bit of perspective, that one of the slides I skipped over was of the Goonies, which was a movie back in the 80s that you all may know. I was assuming people knew it, that some of y'all may have grown up seeing it, because it was a great movie. It's exciting, pirates and treasure and water slides and caves and such. But in that movie, the kid that was the star had asthma, and they featured his use of inhaler through there. When first he was using his inhaler, a lot of things would get stressful. He uses inhaler. And then at the end of it, when he had these victories, he kind of grown up, he's with his parents, he starts using inhaler, and then he throws it away. And what's the message there? The message there is that asthma is a weakness rather than a disease. It's a weakness, and as you get to be big and strong, you won't need your treatment. But we've gone past that for asthma, but I think we're still in that for addiction, where people still are thinking of it as a weakness and the medicine as a crutch. And that's not the situation at all. Like I tried to emphasize that we're actually treating an addiction here rather than using any crutch along with it. Okay. This next question, I see a chat, and ask David, take that one any chance. The United States will decriminalize drug use.
Ooh, I'm glad someone asked this question. So I don't know if anyone's seen it, but you can just Google Oregon. Just about 4 months ago, decriminalized drug use in the state of Oregon. And now, so is there a chance that as a country we will move toward decriminalizing? I think that'll be a tough one. And I like to say, for people who hear that and you go, oh my gosh, decriminalize drug use. I read the entire bill that Oregon passed, and it's beautiful. And it's not legalizing anyone to have any drug or any amount. It's really, people can have small amounts. So it's kind of a balance. But what it did is it takes away the drug war effects, because now, and I'm going to bounce around a little bit. So in Ellensburg, this is so cool. We're so fortunate in Kittitas County. I just started a program with the Ellensburg Police Department where I'm riding along with officers. Every officer has my name and number, and we created resource cards. We're kind of starting a program. It's not decriminalizing yet, but where we can try to circumvent. Can we intervene at the point of contact and get someone to treatment rather than jail? Now, to answer your question, do you think there's any chance the United States will decriminalize drug use? Well, I'm a believer and I'm hopeful. Do I think it'll happen in my lifetime? I'm 53. I hope I have 30 years left. Probably not. But I was really encouraged. Oregon was able to get that bill passed. So I hope that answers your question.
Let me add into that. I saw earlier that on this participants, saw Becky Starnes, Robin Reed, Michaela, all of them involved with the network effort to work at the jail. What they're trying to do, look at where people with opioid addiction present, it tends not to be the medical system, but the criminal justice system. And so those folks I mentioned through the network, trying to coordinate a community response at the jail to help get treatment started. So even though that's not decriminalizing, it's certainly looking at where the people are at. For those of you interested in decriminalization, if you have a chance, you might look at the country of Portugal and what's it done, which has been a model for how you can decriminalize and get better results.
I get excited when I hear that one. And there's a recovery advocate. He's on the East Coast. His name's John Shinholzer, and he's in the film called The Anonymous People. If you want to watch a great film on a lot of what we're talking about, he started a program in a county jail. And one of the things he said is, like, they're all here. If they're all here, let's start helping them while they're here. And we are truly doing that in Kittitas County in some really cool ways.
I guess I had a follow-up for David in terms of language. Sometimes when I'm with patients and I give them their summary, I'll use this as an example, but sometimes, obesity is listed on their medical list of problems, right? Yes. And so for me, it's just a medical term. I'm fairly desensitized to it, but from a medical and a billing standpoint, I can get certain treatments for someone with that particular diagnosis. But if I call them overweight or something other, I can't. So do you know if there's a push sort of in the medical terminology, ICD, international code panels to try to change some of this language?
Yes. So the DSM-5 had a huge shift in language, which was really, really good to see happen. There still needs to be a little work. And then just in our state alone, there's been a huge shift. People who work in the field, in fact, I worked in the field, and this has been 10 years ago. I was a chemical dependency professional. Well, now they've changed the title, substance use disorder professional. So there is movement toward using non-stigmatizing language across the board.
Let me piggyback on that because of your question, James, because I think that's a really good point. And I've thought in the past that the only other condition I know of that shares the type of stigma that substance use disorders does is obesity. I asked at the very start of my talk, can you think of any other condition which it's common, has a high mortality, for which there's effective treatment, and most people are not getting that? Well, somebody with diabetes and obesity, it's very clear that surgical treatment, bariatric surgery, improves mortality and morbidity. Yet, trying to get that done through an insurance company is, like pulling teeth. It's very, very difficult. We still have that stigma on addiction, on obesity, as we do with substance use disorder. I think that is another condition that shares that. So I think they do have that in common. But so eventually we need to accept things as diseases and look at what the best treatment for them is, rather than just saying, well, you need to get over it on your own because it's a weakness on your part.
So there is the post test in the chat on the side. If you, I know Doug was probably going to say this, but if you can complete that post test, we'd really appreciate it. Because as you all know, having data supports these efforts that we're doing when it comes to funding.
Yeah, so again, you all being in the social work field, let me encourage you, just when you'll see families of people where someone is struggling with addiction and would love to see you be able to tell them that they're treatable diseases and they need to be getting help, rather than anything that leads them to put themselves down and not get help. I was focusing on Suboxone because it is generally the best and most available treatment for opioid use disorder. I should mention, methadone is available in Yakima through the methadone clinic, and is also an excellent treatment. Some people, there's another drug called naltrexone, which is an opioid blocker that does have a role in it and can be done. And then the importance again of Narcan or naloxone distribution, that anybody that wants to get a Narcan kit, which is now mostly in the form of a nasal spray, can go by a pharmacy and pick it up. And so anybody that's around people that might ever have an overdose, it'd be great to do that. It's also available through the health department's syringe exchange program, again, free of charge through them. But it's saying basically you don't even have to have a doctor prescription now. The state health department will help you to get that. And it's not even just for people that are using, it's for anybody who's around anybody using. Just go to the pharmacy and say you'd like it, and you can get it. Okay, looks like we've answered the questions for now. Feel free to ever want anything to know. I'm available to try to answer questions anytime, as is David, I'm sure.
Yep.
So
thank you everyone for coming.
Thanks you guys for joining us, and thank you, David and John. Doug is going to try to post this on the network's website. So, and then David, will you have this available on your YouTube channel?
Yep, absolutely.
Okay, great. So I'd encourage everybody to share with anyone who's interested. Okay, thanks again. Look for more of these events to happen in the future.
Awesome.
All right, bye to everybody.
Bye everyone. Have a great Friday.